So this was or is a project that has been done in Glasgow. I'm one of the senior neurosurgical registrars at the Institute of Neurological Sciences. I'm also one of the neuro-oncology fellows doing a PhD in glioblastomas under Professor Chalmers at the Beatson. My supervisor on this particular project was Miss Jennifer Brown, who's one of the consultant neurosurgeons. And so a suspicion has grown in patients referred to the neurosurgical on-call page or through direct to our neuro-oncology MDT have got cranial imaging highly suggestive of a high-grade intrinsic glial cell tumor, that the body scans they have are not necessary. So oftentimes patients should be referred via pre and post contrast CT, as CT is very ubiquitous and the most common imaging modality we have in Scotland, prior to, of course, having more definitive contrast enhanced MRI imaging. And these patients at the point of referral, sometimes contrast CT of the chest, abdomen and pelvis is done, or often advised by the on-call neurosurgical registrar or in discussion with the on-call neurosurgical consultant. And the suspicion has grown that a lot of these patients often have negative body scans. And therefore, a question has arisen, should this be done? Is it needed? But of course, to answer that question, we wanted to have some hard data. And so we did a 12-month retrospective case series in 2018, looking back on those patients. Now, it was a retrospective of the 20 and 18 cohort. We've had COVID and interruptions since, so that was the best year that we could use to identify, of course, before the pandemic came. Some things were affected during 2019, certainly 2020, 2021, 2022. So we had our inclusion criteria. Patients had to have a CT scan at the point of referral, highly suggestive of a high-grade intrinsic glial tumor. There had to be patients referred through to our neuro-oncology MDT, at least discussed at it, either preoperatively or postoperatively. That's some of our minimum inclusion criteria. Patients, of course, had to have de novo presentation of this disease. Patients, of course, there should have been some discussion about extracranial body imaging. And from that, we split our patients into two groups, those who are tissue proven and non-tissue proven, just to see if there was a difference in those patients with an intention to treat surgically in comparison to those with an intention to manage conservatively in the rate of contrast CTs of the chest, abdomen, and pelvis. And so with our results, we had about 131 patients referred through in 12 months. 84 were treated surgically and 47 were managed conservatively. Now, the 47 didn't have a tissue-proven diagnosis of a glioblastoma, but the imaging on initial CT imaging is highly suggestive of, and that's a consensus opinion based on discussion at our neuro-oncology MDT meeting with neurosurgeons, neuroradiologists, neurologists, neuropathologists. So that's a consensus view of that image. And of course, subsequent contrast MRI imaging confirms that view in those patients where there was no tissue diagnosis. And what we found, if we just look at those who are managed and with managed surgically, those with a tissue-proven diagnosis of glioblastoma, the overwhelming majority of those who had a body scan showed nothing. So about 2/3 had a body scan as advised by the referring team or the neurosurgical team, and nearly 98% of those patients who had contrast CT imaging at the point of referral, their body scans were negative. Of those patients who had a background history of extracranial malignancy, apart from one, the overwhelming majority had negative body scan as well. So that's almost very conclusive. Now, body scans in those patients intended to treat surgically doesn't really show anything. In those who are managed conservatively, they often had a much higher age profile. So those who are managed surgically, their median age is, say, in the 50s. Those managed conservatively, it's in the 70s. And in the 70s, you would expect a high request of body scans just because of the patients are older, have more comorbidities, and you have a high suspicion of cancer in general at that age. And that's reflected in the data. So they had a much higher request rate of CT chest, abdomen, and pelvises, but even so, how many of those were positive for disease? Less than 20%. And in those who had a background history of malignancy, only 1 in 3 had anything which was positive or to suggest malignancy on a body scan. So in fact, in group 1, you can almost form a rationale that if you intend to treat someone surgically because they're younger, decreased risk of malignancy in general at that age in comparison to someone who's older, based on the contrast CT, before they've had a definitive MRI, that you do not need to suggest a CT chest, abdomen, and pelvis. In those patients who are intended to be managed conservatively because they're older, have more comorbidities, higher likelihood of just general systemic unwellness, whether it's malignant or non-malignant disease in general, for those patients, we don't have as much of a rationale based on the data to say you should not have a CT chest, abdomen, and pelvis. We would still advise that. So we've had a flow diagram like what we had, and it's certainly my oral presentation, is that actually, if someone comes through to you, it's fit, healthy, no history of any malignancy, you intend to treat surgically, just based from the contrast CT alone, do not advise a chest, abdomen, and pelvis unless the contrast MRI throws more differentials into the mix to suggest potential metastatic disease.